Good evening, sir. How are you?
Just a sec.
Sure.
Yeah. Am I audible?
Sure.
Yes, sir. You are audible now.
Yeah. Okay.
Ma'am, just allow me 1 minute and I can then fix everything
One
and we can
second.
commence. Just a moment.
Yeah. You're all set?
Yes, ma'am. Yes, sir. We can commence now.
I think we are getting a slight echo from your side.
So that's sorted. That's sorted now.
Okay.
Greetings to our viewers. Welcome to another episode of Health Talk brought to you by Medigens. Since this is a lung cancer awareness month, I'm your host, Dr. Vijita, and we have Dr. Balaji Ramani, Director, Gleneagles Institute of Oncology, with us. Thank you, sir, for joining in.
Good evening, ma'am. Thank you for inviting me to the program.
So, sir, as we all know, lung cancer is something that is very, very common, and the incidence of lung cancer among people globally and in India as well is increasing incredibly. So, sir, I would like you to tell our viewers about what actually is lung cancer and what are the early warning signs and symptoms that happen, but most of us ignore.
Okay. So, as you already mentioned, lung cancer is one of the most common cancers across the world. Now, we have data that is getting published everywhere by an organization called RoboCan, which gives the overall incidence of cancers and the order in which it comes, let's say, which is the top cancer and then which is the second most common, like that. So, the incidence of lung cancer has been increasing over a few decades, and over the last nearly 2 decades, it is the number one cancer across the world in both males and females put together. And if you take ladies, it will be usually breast cancer. In gents, it will be lung cancer. So, and overall, if you take the numbers as well, lung and breast will be the top two cancers. Sometimes it will be lung, sometimes it will be breast, like that, how it goes. And what we find is usual symptoms that people might associate with lung cancer are cough. You may have some blood in the sputum that comes. You may have chest pain, either side of the chest, whichever lung is getting involved. And you may have symptoms to where the disease spreads. For example, it can go to the bones. So that particular bone will have symptoms of pain or fracture related symptoms might be there. And you may have brain, metastasis, as we call them. If it goes to the brain, then you may have headache, you may have vomiting, you may have seizures, or what we call as fits in common parlance. So all these might happen. So essentially, lung has one is the local symptoms, and then it's going to be the metastatic disease symptoms. The local symptoms are you're going to have cough, bit of breathlessness, and difficulty in breathing with sort of like blood in the sputum. So these are common symptoms, and of course pain might happen. And the rest of the symptoms depend on the areas to which it spreads. So early warning signs, if you take it, unfortunately, lung cancer in the early stages is pretty asymptomatic. You don't have that much in terms of symptoms. Most of the patients who present to us with symptoms will already have disease that is at least stage 2 or 3, or in many cases even stage 4 at presentation. That's the unfortunate scenario, because some cancers will have early symptoms. Lung cancer, unfortunately, in many cases will not have early symptoms.
That's an insightful information, sir. Sir, so like places like Delhi, you don't find non-smokers here, sir. We are all smoking people because either people are directly smoking or we are indirectly smoking this polluted air thanks to the city which we live in. So most of the northern India right now is covered in haze. So obviously, how does this toxic AQI silently damage the lungs? Because here from a newborn till a 70-year-old is smoking. Nobody is a non-smoker here, either actively or passively. So how is it affecting us in the long run?
So yeah, this is again very pertinent question. World over, the people will know that lung cancer is something that commonly happens as a result of smoking, and otherwise it's uncommon. But one point I wish to stress here is, like, it's not just smokers. Even in non-polluted areas, non-smokers can also get lung cancers. That is one possible misconception that people might have, that only smokers will get it. Though it is very common, you will find that if you take 100 patients with lung cancer, almost 90 of them will be smokers, and about 10 of them will be non-smokers. This is the rough number. 80 to 90 will be smokers and the rest will be non-smokers. So this is one basic fact. In today's world, of course, it's not just the first hand smoke. In smoking, we have something called first hand smoke and second hand smoke. So first hand smoke is basically the person is directly smoking. So they are using a cigarette, and that is all, cigar or a pipe. And that is another misconception. People think that using a cigar or using a pipe or a hookah, all these are things that are okay to use. They are not toxic. They do not cause lung cancer. The reality is, any form of tobacco you use, be it a hookah, be it a BD, be it a cigarette, be it a cigar or a pipe, whatever you use, all of it will cause lung cancer. So the size of the particles will differ depending on the type of smoke that you're getting, but all of them will cause lung cancer. That is the first thing that we have to remember. The second thing is second hand smoke, in the sense that if you have somebody in the house who is smoking repeatedly, like they smoke a pack or two every day, then the environmental tobacco smoke, ETS we call it, or second hand smoke in common terminology. So your husband is smoking, then you get exposure to tobacco smoke. And that is important, because if you take a normal person who doesn't have any history of smoking or other risk factors, let's say their risk is, for example, let's say it's about 5%, then a patient who's going to have second hand smoke, their risk becomes double. It's almost 20, I mean, it's going to be, instead of 5%, it's going to be 10%. This is just a rough number I'm quoting to make you understand. It's not actually 5 and 10%, but the risk is double when you are exposed to second hand smoke. And that is one reason why the government of India banned smoking in public places, a very welcome move. I find even now in Western societies, I think UK has not banned it, China has not banned it, US also, I think smoking is not banned in all the states. Some states selectively they do, but most states people continue to smoke. It's considered a civil liberty. But India has been a little ahead here, and we have actually banned smoking in public places. The actual reality that many people may not follow it. There are areas where people still smoke in public. All this happens, but by and large, the impact has come down because of this rule that has come in from the Indian government. A very welcome move. That is one. Second thing is, other than any form of tobacco, what are the other things that can cause lung cancer? Here is where the component of your AQI or air quality index that you are referring to and alluding to comes in. So the pollution that we have widespread in many places across the world, especially in India. India ranks somewhere around the fifth or sixth position as far as the polluted cities are concerned, the number of polluted cities are concerned. And Delhi is, as we know, though it's the national capital, it's one of the worst affected in terms of pollution, and that is of concern for us. And we look at AQI in terms of, like, up to a level of around 100 is acceptable. Less than 50 is the ideal thing. Up to 100 is fine. Till 200 is moderate, and beyond 200 is all very bad. And what we are worried about, what is this AQI or air quality index, and what are we measuring? So we are looking at something called as particulate matter. So PM we call it in short. And this particular matter, whenever you have like smoke, in that, what is the size of the particulate matter that we are having? So that is going to be 2.5 to 10 microns. So these are the ones that will actually go into the lungs, and they will cause a lot of they do cause cancer. They are what we call as carcinogens. There is an agency in France called as ERC, International Agency for Research in Cancer, at Lyons in France. Their job is to study all agents that can potentially cause cancer. Like, for example, we know that smoking causes lung cancer, oral cancer, etc. So this is by studies. They've done a lot of studies, epidemiological data. That is how they classify an agent. And you have three categories: class 1, class 2A, 2B, and then class 3. So class 1 are proven cancer causing agents. So this is where your smoking, your alcohol, all these are going to come. And we have to remember that particulate matter 2.5 and 10 are class 1 carcinogens. So they are as bad as smoking, and that is again reflected across the world. You find that there is an increase in the incidence of lung cancer, not just the smokers, but also in other people, directly related to pollution. So this particulate matter contains many gases as well. Like, you have uh, nitrogen dioxide, you have sulfuric oxide, you have ozone, O3 as a component. Ozone is protective, but in the atmospheric level, it is dangerous. Then you have radon gas exposure, you have uranium exposure. All this can happen. So all these are directly related to causation of lung cancer.
So Delhi is clearly more than 2.5. It ranges between 2.5 and 5. So I think people here are somewhere at the risk of inhaling these dangerous particles. So, sir, as you mentioned earlier, like the cancers, especially the lung cancer, may have the causes like smoking and this pollution as well. But some people who do not smoke, they also develop lung cancer. So, is the genetics or any hereditary cause involved in that? Does it contribute to someone getting the lung cancer?
Yeah, now there are some cancers which are, by and large, what you can say is a higher component of hereditary uh, risk is going to be there. Like you say, breast cancer, ovarian cancer, pancreatic cancer, colorectal cancer, all these are directly linked, and we know the genes also which are responsible in many cases. So you have, for example, Angelina Jolie is a world ambassador for hereditary risk of breast cancer. She had a mutation and she underwent preventive surgery for breast and ovarian cancer. So like that, you have these cancers, basically breast, colorectal, ovary. These are the top three, and with others also coming in. Now, as far as lung is concerned, there is an association with hereditary chances. Like if someone in the family has cancer, lung cancer, then there is a twofold increased risk. It's almost like 1.8 times. Suppose, as I mentioned, the risk is 10%, then in a family member, the risk will be 18%. To quote the numbers, there are a few studies that I've done, but there are not particular genes that are being identified. That has so far not happened or gotten confirmed in lung cancer. So yes, there is a risk, but we don't know the particular genes in great detail as of date. So there is a hereditary component. So if somebody in the family gets lung cancer, there is a twofold risk, roughly speaking.
So, sir, what are the lifestyle changes that can prevent somebody getting lung cancer? And also in the cities which are highly polluted world over, not only in India, world over, most of the cities are highly polluted. But and most of majority of people have to live in these cities basically for their work commitments. So, what are the lifestyle changes or the preventive measures that such people can take so that they reduce the risk of developing lung cancer?
So there are two parts to this question. Like lifestyle changes can be at a personal level, and those that can happen from a institutional perspective and things like that. So at a personal level, it's very simple. Quit smoking or any form of tobacco. It's a very very simple thing to do. All of us can readily do it. In cancer, we call it as modifiable and non-modifiable risk factors. Things that you can change and things that you cannot change. So smoking or any form of tobacco consumption directly comes under the modifiable risk factor. So we know that we can stop smoking anytime we want. We can stop smoking. So do that. That is something completely in our control. And till date, even though we have other risk factors which are there, 80 to 90%, as I mentioned at the start of the program, 80 to 90% are directly as a result of use of some form of tobacco. So that is completely in our hands. So one lifestyle change we can readily do: stop smoking in any form or usage of tobacco in any form. That is not just for lung cancer. It is also in terms of oral cancers, throat cancers as we call them, pancreas cancer, bladder cancer, colon, breast. Almost like 15 cancers in the body are associated with smoking. So usage of tobacco, if you stop using tobacco, all this can be prevented completely. So or to a major extent, the risk can be reduced. So that is one lifestyle change that I want all of the people to do. The second thing is, yes, we are living in polluted cities. We cannot really change what is happening outside. We cannot just shift a place and go. None of us practically can do it on a day-to-day basis. Or you move to a new place, then that is going to get polluted in some time. So it's not practical for many of us. What we can do is use a mask. So in Japan, for example, it is a routine practice to use a mask. Almost day to day they keep using it. And China, again, they have started using it in some places. So it is again pretty simple. Previously, people used to be worried, and you go, people will stare at you if you wear a mask. COVID for all the bad things that it did to us, has again made mask kind of like, anybody who goes with a mask on the road, nobody looks twice. Okay, he's wearing a mask, that's it. They don't even look twice at him or her. So that is something we can do. Whenever you're going in any kind of environment outside the immediate home or controlled surroundings, so to say, you can wear a mask. This again has an impact on filtering out most of the particles. Even a routine cloth mask will do. You don't need an N95 or things like that. That if you have, it's fine, but people are not very comfortable, and those are slightly on the expensive side and all that. So you can just wear a regular cloth mask and wash and reuse it. That itself will take out many of the heavy particulate filters and things like that. So that will, to a major extent, help in preventing lung cancer due to pollution. And of course, the next thing comes at a policy level, where the government is making plans and policies. One which I mentioned, like stopping smoking and usage of tobacco in public places, taxing cigarettes so that people use it less. The content varies, the amount of cigarette, the tobacco which is there in say smoke, all that, so that can be regulated. You do have one thing which I would probably look at from a policy level, which can be implemented, is getting in vaping as an alternative to smoking. So currently, electronic cigarettes are banned in India, whereas cigarettes are okay. So that is a sort of like, I wouldn't say it's actually a very nice way to do things. You either ban everything, you say there's no smoking of any form, that is fine. But then you allow cigarettes, but you don't allow nicotine-based devices. Many people find it difficult to quit smoking. For them, vaping is, I'm not recommending vaping. This is usually used as a device to quit smoking, because there are two components in tobacco. One is going to be the actual tobacco component, the other one is going to be nicotine. Now, nicotine is the addiction forming agent. And though tobacco is the agent that causes cancer, nicotine by itself is so far not proven to be associated with cancer. So there are a lot of other things that can happen. Nicotine by itself is not a safe chemical, but overall, for people who are currently smoking, you can definitely get a vaping device that is much more safer than a cigarette smoke. That is what I'm trying to say. It's not that that is the safest instrument, but for people who want to quit, that will be a better way of doing it. So that can probably be a policy decision that can be done. And of course, looking at pollution, looking at other industrial areas being away, and treating the smoke in some way so that it doesn't cause pollution. All these are things that we can look at a policy level to make sure that people are a little protected.
So that's a good message to our viewers, that in this kind of polluted cities that they live in, simple mask can prevent them from getting any kind of lung infections, and also reduce the risk of cancers. So sir, as you mentioned about vaping, we hear a lot of concept about this popcorn lungs in young adults. Is it related to that, or is it completely something different?
No, popcorn calcifications we call them, and popcorn lungs is the appearance they form. It's not got nothing to do with
Okay.
popcorn. Popcorn is
So
correct.
it's not related to vaping as such.
Nothing. It's not directly related. You do get infections and things like that. Vaping is not safe. I'm just saying vaping is safer than cigarettes. That's the only thing. So people who are long-time smokers or find it difficult to quit, for them using a vaping device is a better way, because the nicotine part is taken care of, so they don't go back to the cigarettes. Many people who try, they can't quit. So we go back to vaping, that is understandable. But I don't want people to start taking to vaping as an habit. That is not safe. You're
That's
already
not.
smoking, then you can quit over. That is what is the message that we should give here.
So, sir, what is the difference between small cell lung cancer and non-small cell lung cancer?
Yeah, so this is interesting, because many people, the word cancer is something they equate to, it's all one single thing. They group it all or lump it all together and say that cancer is that. That's it. Even doctors are not really aware of the various types. People who are non-cancer specialists, not everyone is aware of all the types that are there. Saying that somebody has cancer is just like saying you have a shirt. Like right now, you can see that you have a top, I have a shirt, and the gentleman here, he's having a t-shirt. So it's like you have got so many varieties in cancer, even in the same organ, and across the body there are so many organs. Every organ will have a different type of cancer that can come. And in the lung, you grossly classify it as two types. One is the non-small cell type, the other one is the small cell type. This is basically based on the appearance that you look at under the microscope. So the cells are small in the small cell lung cancer, and the cells are average size or larger in the non-small cell lung cancer. And again, why we group it together as two different types is the management is different. The way you treat these two lung cancers is different. The non-small cell is by and large the most common variety. Almost 80% are non-small cell lung cancers, and these cancers are the ones that are usually treated by surgery and then other modes of therapy like chemotherapy, etc. Whereas a small cell lung cancer is generally a more aggressive variant where the main modality of treatment will be chemotherapy and other forms of systemic therapy, plus add on we will be doing maybe sometimes very rarely surgery is used. Grossly, if you want to remember, you can just say small cell surgery is a kind of like a very rare event, whereas in non-small cell you will tend to use surgery, chemotherapy, everything.
So we've got a lot of information about lung cancer as such, sir, from you, but let's come on to the screening and diagnosis now. So who should get screened for lung cancer, and at what age? What symptoms that the patient should show immediately that they should go and get screened, and at what age?
So I would want to clarify a few things with regard to what is screening first. Now, many people think that when you go for a test after you get some symptom, that is called screening. No, it is not. A screening is something like a master health checkup for cancer. So when you go for a master health check, let's say somebody turns 40, they go and have their sugar levels checked, they have their BP checkup, they have an ECG, they have a treadmill test, they have blood tests. So all this is being done not because they have symptoms. They just want to have a check to find out if they are doing okay. So that is essentially a screening test. When you say what you call as a master health check, is essentially something like a screening test. So in master health check, we're looking at different things. And master health check is not really a comprehensive thing. It depends on what tests you're doing and what is being screened up. Cancer screening can be a part of master health checks. It can be done separately also. So we have to understand what is being done here. So some people will say I had a master health check, everything was all right, but then I turned out to have cancer. No, because cancer is not usually a part of master health checks, or at least very few will be tested as part of a MHC. The other things will need to be done separately. Now, if you take up lung cancer in particular, routine screening for lung cancer is not indicated for all people, because we have some cancers you have routine screening. For example, breast cancer, all ladies, whether they have symptoms, whether they have a family history, whether they are feeling all right, whether they want to or otherwise, all ladies from the age of 40 should undergo a mammogram testing once in a year. So this is something that many of you probably know. Pink October comes every year in October. There is a big awareness program on on breast cancer, and we talk a lot about it. And then we say get a mammogram done. That is the easy way to pick up an early stage cancer, and then we can sort of like cure almost all patients who are detected this way. So that is for all women from the age of 40. The same way for men and women from the age of 50 years, we recommend a colonoscopy once in a decade. That is once in 10 years, we can do this, and we can sort of do a colonoscopy once in 10 years and pick up very early colon cancers, colon and rectal cancers, and it becomes very easy to treat them at this point of time. So these are two tests that can be done. And again, for ladies, you also have the pap smear test or cervix cancer screening test, which is starting, usually I recommend from the age of 30. In the Western world, it's 21, but at least from the age of 30, we do it once in 3 years, or if with a DNA test, once in 5 years we do. Again, for all women, we can do this. Now, these are the common screening tests that are available or recommended in cancer screening for almost everybody in that age. Others are selective screening. So lung cancer falls under selective screening. So what we have is something called as a low dose CT test. Now, what do you mean by low dose? Normal CT scans will have a particular dose. For a test to be called as a low dose CT test, we consider the units of radiation. It should be 3 milligray, as we call it, 3 units of radiation, or there is another unit called 1.5 millisieverts. That is actually the definition. So the total dose of exposure for an average size adult of around 70 kgs should be around 1.5 millisieverts. That is what is called as a low dose CT screening protocol. In essence, you can remember it's like a CT scan of the chest. Now, who needs the CT scan? So here we have two criteria. One is the age of the person, which is 50 years and above. That is the first criteria. Starting from the age of 50, every year a low dose CT test has to be done. The second is, does everyone need it? No. It is for people who have something like a 20 pack year history of smoking. Now, what is this pack year? Pack years means if a person is smoking one pack of, a pack usually contains 20 cigarettes. So one pack of cigarettes for 20 years, if he is smoking on an average, then it is called as 20 pack years. Number of packs per day into number of years, that is known as a pack year. So if his lifetime he has been smoking, his or her lifetime, if they have been smoking around 20 pack years, then they are the people who are eligible to get this screening test done. Can others do it? Yes, they can, but the benefit is mainly for these people. So two criteria, I'll go again. One is 50 years of age, second is 20 pack years of smoking. If you have these two, both of these boxes are ticked, then you have to undergo a CT test once in a year, preferably a low dose CT test. Some places you may not have a low dose protocol, but you can just do a plain CT test. No contrast is needed, nothing. And CT test is a relatively safe investigation. Overall, I mean, there is some radiation exposure, so that risk is there. But overall, if you look at it, if you are coming under because a person who has been smoking a pack of cigarettes for 20 years and he has reached 45, 50 years of age, then the risk of him developing cancer and that not being found out is much higher than the risk of radiation exposure due to CT scans. So for them, we recommend a CT scan every year from the age of 50 years. That is what is the recommendation. Can others do it? Yes. For example, if people in Delhi have been living in a very polluted environment, or you're working in a factory where there is not much of sort of protection for your face or other things, and you've been exposed to that, particulate matter content is there. All these are people. So nobody is actually preventing a person from undergoing a CT test, but the recommendation is only for these people.
So, sir, this will greatly help our viewers, because if somebody has been smoking for a long period of times, this is a very good piece of information that they should get themselves screened after they cross the age of 50, or they've been regularly smoking. Thank you, sir, for that. So let's come on to the treatment and innovations in today's time for this deadly disease. What are the latest advancement in lung cancer treatments, sir? Like the immunotherapy, targeted therapy, etc. What is there for lung cancer if somebody has got that? And like you said earlier, that the patients generally get diagnosed at the age of, at the second stage or third stage. So how does the treatment vary in each stage?
So yeah, again, coming to that question, grouping it as small cell and non-small cell. Grossly, as I told you, small cell is usually treated by chemotherapy, addition of radiation later on. So that is a relatively rare tumor. Now going on to the main type of lung cancer, which is the non-small cell type. So here, if you are lucky and if you are getting it detected on screening, then it will be a small tumor, usually around 1 to 2 centimeters, which is a stage 1 cancer. So when up to 3 centimeters is considered to be a stage 1 cancer. When you have this kind of cancer, then more often than not, those cancers can be highly curative. Now, most people want to know what is the cure and what is the stage and all that. Grossly speaking, stage 1, 2, 3 are increasing sizes of cancer. 3 centimeters, 5 centimeters, more than 5. And then stage 4 is something where the tumor goes to other areas, other organs and all that, where we call it as stage 4, where it is metastatic cancer. Now, stage 1, 2, 3 are generally considered to be curative cancers, where the stage is considered to be curative. Stage 4 maybe not so. Many cases it is not. And what is difference in terms of cure between these stages? So if you treat 100 people with particular stage of cancer, what is the survival or the cure? So at 5 years, the survival of a patient, if you treat 100 patients with stage 1 cancer, the cure rate can be as high as 80%. Suppose it is stage 2, the cure rate comes down to around 60%. There is a 20% drop. And then you have stage 3, where it falls down to somewhere close to 40. And stage 4 is generally considered to be incurable, where hardly 10% of patients might be alive at 5 years. So this is the rough statistic. It's a rough number. And when you look at it as to what do you do for each stage, how do you identify? Now, people ask, when do I get the screening? I already told you, whether you have symptoms, whether you don't have symptoms, nothing matters. From the age of 50, if you have a long standing history of smoking, start doing a CT test once in every year. That is the simple rule for screening. Now, what about symptoms? When do I get a CT test with symptoms? When do I need to go to the doctor? Again, the thumb rule is, because cancer symptoms are kind of like it can be anything. There is no one particular symptom for lung cancer or for any cancer for that matter. It depends on the organ, it depends on the size, so many things are there. So as I told you, suppose the tumor goes to the brain, I said headache is a symptom, but I'm sure all of us in our life would have had a headache at some point of time or the other. So it doesn't mean that everybody with headache is going to have a cancer which has spread or anything like that. But when you have a persistent headache, when it lasts for more than 10 to 15 days, then you go to your doctor and have a checkup and probably have a scan and other things. So the thumb rule is any symptom that goes on for more than 2 weeks, that is something for which a test has to be done. You have to go consult your doctor, have a checkup. It may be an endoscopy, it may be a scan, it may be a CT, it may be other things. So all this will need to be done when you are doing it. So thumb rule, 2 to 3 weeks is the timeline for any symptom beyond which you have to go and have a checkup, medical checkup with a particular doctor, in the sense that depends on which organ. Let's say if you have cough and other things, you'll go to a chest physician or to a internal medicine guy, and then you will have a checkup, maybe a scan and all that. Suppose you have headache, then you maybe it's a neurologist. You may go to even your routine doctor. He may give you some drugs for 2 3 days. Doesn't settle, then they will go and do the next test. And again, another word of caution: go back to the same doctor, because doctors have a set of like protocols. You will say that initially when you go, like every patient with a headache, we don't ask for a CT scan. We do it, we just give initial some treatment, look at the common things. Does the patient have eye symptoms? Does he have a ear problem? Does he have a nasal problem? Does he have cough? So common things are ruled out first. You give some treatment for that. If it doesn't respond, that is when the next thing will be done. Most of our Indian patients, because they go to one doctor, they don't get relief in 2 days, then they go to another doctor, keep jumping. So the first doctor has no clue, or the next doctor again has no clue. They don't know that they have been taking medication. So everything starts from scratch. So there is going to be a delay. So generally, trust your doctor, go with him, say that it doesn't get resolved, do I need to do something? That is all is the thing that you need to remember. And next, going on to treatments, in early stages, the people is going to do surgery. In terms of innovation in surgery, previously it used to be a big scar, along the side of the chest. There will be a big scar we have to open out and we have to do. Currently, we do either a laparoscopic surgery, not laparoscopic, we call endoscopic surgery, VATS, video assisted thoracic surgery, VATS for short, or RATS. RATS is robotic assisted thoracic surgery. So either robotic surgery or an endoscopic surgery is done to remove the lung. Affected portion of the lung can be removed and it can be brought out by that. Through a small incision, we can do this. So the recovery is much faster. Practically speaking, even if you remove, like say, there is right lung and the left lung with about 3 on the right side and then 2 parts on the left side, you can remove one part of the lung, and in most patients will get discharged in about 5 days from the hospital. Okay, no problem. You remove a portion of the lung and nothing else is there. They can just go walking after doing the surgery, and not much pain either. You can just take a Dolo tablet and that's all will be needed. That's how easy lung cancer surgery has become. There are a lot of complex surgeries also that can be done. As you go near the central part of the lungs, the surgery becomes more complex. But even these can be done today by robotic surgery and by endoscopic surgery. So that has changed the surgical management a lot today, and much more advances have come in anesthesia. Previously, doing surgery, lung surgery was a very complex thing. Now, with the advent of a lot of cardiac surgery improvements and the same anesthesia techniques, we can do pretty much major surgeries in the lung today, in terms of either robotics or endoscopic, or we give some chemotherapy inside. All these are things that can be done. High talk we call it. So many advances are there as far as the lung surgical part is concerned. What has again changed in cancer management is, we all know that chemotherapy has been in use for quite a long bit of time. We do have other therapies now, what we call targeted therapies or immunotherapy. Targeted therapy is like you look at the particular markers, a personalized treatment, so to say. So that kind of personalized treatment is possible today, and we do the treatment like that, and we look at the markers. Basically, you look at the tumor assessment, you find out which markers the tumor is having, and based on that, you give the drug. So that is known as targeted therapy. So you target a particular agent which is there in that patient, and lung cancer is one where this is very much used. Today, for treating lung cancer, any biopsy, you need the molecular studies as well. Without that, you cannot start the treatment, because even though we say it's a non-small cell lung cancer, even though it may be a particular type called adenocarcinoma, still there are multiple types depending on the type of marker which is present, and that will decide the drug that the person is going to get. So that particular patient, each patient, the drug and the regimen, everything will change based on that. So that is one thing. Targeted therapy is used hugely in lung cancer. Second thing is immunotherapy. Again, in recent times, what has changed other than a conventional treatment is immunotherapy. Both targeted and immunotherapy have changed the face of lung cancer. And what used to be in our times when we were doing our, sort of like studies on, whenever I was doing my super specialty training and all, lung cancer was considered a death sentence. Most people will present late, and cure was very unlikely. In the rare case when it is incidentally detected, by luck we find it early, then we can cure. Stage 3 and 4, most people will die of lung cancer. Today we are seeing a lot many patients with a favorable type. When you have it, then they survive for a long time by giving these drugs, by surgery, by these drugs. You can basically look at a long term cure with lung cancer with these treatments today. That is possible.
So this is a very, very hopeful message for our viewers, because lung cancer, as scary it sounds, but the information that you have given, that the advancements in surgeries are not that complicated. It does not. The post-op recovery is very good. I mean, as you said, people can get discharged even in 5 days, and the pain can be cured by a simple tablet like Dolo. This is a very, very hopeful message, sir, because lung cancer is really very scary, and yeah, people don't know what are the advancements. So thank you for this information, sir. So let us talk about the life after the treatment of lung cancer, sir. So how important is pulmonary rehabilitation after the lung cancer treatment? What are your views on that?
Very important. See, any cancer, all cancer starts off like, initially there is no cure. That is how it's all started. Most of the treatments for cancer, though surgery was available, we all realized that cancer is different from other diseases in that, let's say you have a gallbladder problem, you knock off the gallbladder, and that's it. Within a month, you're back to your feet. Not even a month, now it's about 10 to 15 days, and then you forget about it. You don't need to remember that you ever had a surgery, and that's the end of the story. But on the other hand, even if you have a lung cancer or any other cancer in the solid organs, as we call them, surgery alone is not enough. Surgery is an important component of treatment. Early stages are mainly managed by surgery, but once it is done, then you need these additional treatments. But all this treatment, let's say it lasts for about a year or 2 years. After that, what do you do? So now we look at rehabilitating patients, how to get them back. See, ultimately the purpose is not to just make a patient bedridden or not go back to their life. They have to get back to their normal life. That is the whole purpose of any kind of treatment. So today we focus on the rehabilitation aspects as well, and we have programs where the patients are put on an active regimen. We have a whole team where they take care of the diet and nutrition. We have exercise and physiotherapy coming in as a part of this. We have lung specialists who will help them with their breathing patterns and routine things and all that. So doing all this is not that very difficult. By and large, it's taking healthy diet, healthy exercise, doing some pranayama. All this is something that any of us actually should do, irrespective of whether we have cancer or not. And that's the same thing that will be done. Of course, in a patient with cancer, you have to tailor it according to them. A regimen, if they have undergone a lung surgery, then supposedly based on the number of portions of lung you have removed, then you will give them some techniques to improve their breathing. All these are available today, and that is how the rehabilitation is done. But remember that even during chemo or targeted therapy, the exercise and all that can continue. It's not necessary. Only during surgery, probably. But again, like immediately after surgery, on the second or third day, we will start some ball exercises, like blowing a balloon. That kind of exercises will be started for the patient. So these things, we call it as spirometry. All these will be started right in the post-operative period, even when the patient is in the ward. And the same way during chemotherapy, we advise light exercise, just walking, some light stretches. All these things can be routinely done. It's a misconception that patient should be resting in bed. No, not necessary at all. If they feel tired, yes, they can take rest. But otherwise, light exercise actually helps improve the outcomes. And most importantly, quit smoking or tobacco use. Now, this may sound very counterproductive. Many patients continue smoking when non. It may sound like really a stupid thing to do, but many people are not able to quit. So that is, and there are direct results that show that people who continue smoking have a 50% cure rate as compared to people who don't. So it is, for the future and for the current treatment, it has a very, very, very important impact. Other thing that has come up in recent treatments is, sorry, I forgot to mention that, is radiation treatments. Now, some patients, when they are very old and they are not fit for surgery, we do have some radiation treatments for the smaller cancers. We have something called as, SRS or SBRT, like it's, stereotactic radiotherapy. All these are available, which can kill the small tumors without any surgery also. So that is also available today to cure lung cancers.
So basically, rehabilitation after any treatment is important. For example, immunotherapy or targeted therapy, or even surgery. Rehabilitation helps the patient get back to the normal lung capacity, so that they can have their functional independence back.
Absolutely.
So, how can how can patients cope up uh, with breathlessness or fatigue or anxiety post their surgery? Does rehabilitation help that in that as well?
Definitely. See, one thing is we have some, specialists with us. We call them as, all of us know psychologists who help us out whenever we are down mentally. So there is a specialized branch of of psychology called as psycho-oncology. So we have psycho-oncologists who are available who work with us, and it will start right from the moment they see us first in the OPD. We give them counseling. They will be talking to the patients. They'll be telling them. We'll be giving a broad outline of the treatment and all. But these people will sit with them and talk to them, address their fears. They feel more comfortable talking to somebody who is a non-doctor, so to say, because to a doctor they will be talking about their medical part of treatment and all that, but the other things, their fears, their worries, their job, all these are things that will be addressed when they have a session with the psycho-oncologist. So this is one. The next thing is the physiotherapists and the pulmonary medicine people. They will help out with the exercises, with the balloon blowing kind of thing and all that. So again, light exercise, walking, moving them, stretching, what should be done. They are aware of what are the limits. They will also integrate with us on what to do, what not to do, either post surgery or post chemo or immunotherapy. They will know what to plan for. So all this will be sort of like planned as a program for the patients, and they will go through that. And that really helps. That makes things definitely easier for them. It's all pretty simple things to do. It's not very difficult. But then when you have sort of like a program in place, it runs by itself. You don't need to really look at it or think about it. And that is how the rehabilitation happens, and it really helps the patients recover both physically and mentally and psychologically from the trauma of cancer.
Thank you, sir. Thank you for that. So, sir, we'll go to some questions from our viewers that have come up.
Yeah. So I can see the questions here. One
Yeah.
question is for someone who has quit recently smoking. How long does it take for the lungs to start healing and the cancer risk to decline? Now, in one sentence, if I have to say, the risk never comes back to normal. The moment you start smoking, your risk starts going up. And we have a definition of a smoker. Anybody who has smoked more than 100 cigarettes in their lifetime is called as a smoker. Less than 100 in your lifetime, I'm not talking about a year or so. In your lifetime, if you have smoked less than 100 cigarettes, that's considered to be a never smoker. There are definitions which are given by WHO, World Health Organization. So somebody who has not smoked even 100 cigarettes in their life, they are considered to be never smokers. Anybody who has smoked more than 100 cigarettes in their life, there is a definite risk of cancer, and that is again related to the dose, how many cigarettes, the pack years which I mentioned. The risk goes up with every pack year of cancer, and when you are at a risk never comes back to normal. It comes to somewhere around two times the normal. As I mentioned, let's say 10% is the average risk. Person who starts smoking and then quits at some point of time, the risk can come back to around 20%, but it never reaches the 10%. And this is not just cancer, even for heart attack, there is, for example, heart attack or pulmonary edema or whatever, the pulmonary emphysema and all that we call, all these risks also take quite a long time to reverse. It takes almost like 5 to 10 years for the effects to, after quitting, to come back to relatively okay levels. Still kind of like some of them never reach the normal, but it is a long time. But one thing is, the moment you start, these effects start appearing, the side effects start disappearing, and they will become better over time. So the best time to quit is always what we say is yesterday. It's not even today, it's yesterday. So stop immediately. That's the baseline. The next question is something on the radiation treatment that
Radiation
can
treatment,
affect,
sir. Yeah.
yeah, can it affect the healthy parts of lungs and heart, and how do you minimize that risk? The answer is yes. Radiation is like, it's like even something which is good can turn out to be bad. So radiation can cause cancer, radiation can cure cancer. Most cancers, radiation is a part of treatment. But when we are giving radiation to the cancer bearing area only with some margin, so that area only will be radiated as far as the treatment is concerned. So can it affect the healthy parts of the lungs? Yes, it can. But we try, and we have a lot of methods available now. There are a lot of precision treatments which are available, so that the healthy part of the lungs or any other body receive a much lower dose, so that the side effects can be very much reduced. So that is what is routinely done today. In fact, the planning is a lot more precise. There is a role of AI, machine learning and all that, where the machine will give the plan, and then we will look at the plan, find out whether the dose is low. All this is done as a routine. AI, it's a buzzword today, but this AI in radiation has been happening for the last decade or more than a decade and a half. IMRT, we call it, that has been there in place, where the machine will generate the plan. We map out an area and we give, and the radiation treatment plan will come, and then we will decide which plan to go for, which is the least side effect wala plan. So that kind of thing we will do.
So this is a good question. What is the current potential of TCR or CAR T therapies in lung cancer? That is the solid tumors.
Yeah, so CAR T cell therapy is another buzzword that is happening as far as medical technology and medical treatment in cancer is concerned. So CAR T cell is basically chimeric associated T cells. What essentially happens is we take the patient's blood. Now we have our own immunity. Immunotherapy is a form of boosting your own immunity to work, and that is proven to work in a lot of cancers. In the last almost like 8 years, immunotherapy has taken great strides in all cancers. The same way, CAR T cell therapy is proven to work today in most of the liquid cancers, as we call them. Liquid cancers is like blood cancers, your leukemias, lymphomas, and all that. That is where the main role of CAR T cell therapy is there. Where the patient's blood is taken, the T cells, which are the immunity causing cells, are filtered. The ones that act on the cancer are taken. They are enriched, and then they are put in the patient's body again, and they will go and attack the cancer. This is the gross principle of how CAR T cell therapy will work. But CAR T cell therapy by itself in solid tumors is still evolving. The role is not yet proven. It is all being worked on. A lot of research is happening. We expect results to be there in the next couple of years or even earlier. A lot of teams across the world are working on this. Currently, it is already proven or being used in liquid cancers, so in blood cancer. In solid tumors, it is under study. It is still not proven.
So one more question is there. What are the emerging environmental carcinogens linked to lung cancer beyond tobacco, such as, yes, you told about this, such as PM 2.5 and radiation
Something they
exposure?
already answered, no? So PM 2.5 and 10 radon gas exposure. Radon is something which is present in indoor housing in chula, like when we have the house stove and all that. So those are areas where the radon gas can be detected. And on uranium and thorium, CCOs, they are naturally present radiation. So all these are considered to be important. The role is being evaluated. Pollution part of it, I already told. It's a proven carcinogen. It is a proven cancer-causing agent. Radon is also a proven cancer-causing agent, but the extent is not. So whether we get enough when we are indoor, when we are using all this, we don't know. But in general, it is better to avoid. If possible, try to avoid that indoor cooking scenario.
So what are the criteria to decide for the chemotherapy, radiotherapy, targeted therapy, or immunotherapy for the patient? I believe, obviously, it is about the type of cancer or the stage of lung cancer that a patient has.
Yeah. So as far as chemotherapy is concerned, almost all patients will need chemotherapy except for the very early stages, less than 1 centimeter and a very favorable subtype. Most patients will kind of require chemotherapy, the traditional chemotherapy. Radiation will depend on the extent of disease and all that. So small tumors, nothing further except surgery, nothing further. Probably a bit of chemo might be needed, otherwise nothing. But anything which is more than 3 centimeters will, or more than 2 centimeters even in many cases, will require some form of radiation and chemotherapy, all that. Targeted and immunotherapy are decided based on the receptors. As I told you, the molecular markers. We look at the tumor, we do a biopsy. Now there are two types of biopsies. One is the surgical biopsy, where you remove the specimen, send it, and then study it. Then you have small biopsies where you put in a needle and access the tumor, where it's a very big tumor where surgery is not possible. Then you access the tumor, take out bits of tumor, and then you study that. And in that you do the molecular testing. These are the common ones. There is also something called as liquid biopsies today. Now, there are patients where the tumor might be in a critical area, because we know lungs are very close to the heart. It might be very close to the major vessels of the heart, where we cannot do a biopsy for whatever reason. The area is not accessible. Such patients, we can just do a peripheral blood sample, just like taking a blood test we can do, and we do analysis of something called as CTCs, circulating tumor cells. Then there's something called as circulated tumor DNA, ctDNA we call it. RNA, the same way, can be studied. So all these are newer tests, and today it's an accepted modality in lung cancer to, especially in the follow-up of patients with lung cancer. We try to take a biopsy, and in the follow-up, we want to look at whether there are still tumor tissue, whether it's responded, whether it has changed. All this, if you want to study, we can just draw the blood sample and then study, because doing a biopsy repeatedly is difficult. So once you can do the biopsy, after that you can draw the peripheral blood. In some cases, even the primary diagnosis itself can be made by the peripheral blood sample. And all cases will undergo this mutation and molecular testing. When we say mutation, we are looking for molecular, we are looking for mutations, we are looking for what we can call as gene amplification. There are multiple terms which are used: chromosomal abnormalities, ploidy, so many factors will be analyzed. And then IHC, we call it tumor markers, as we call which tumor is lighting up with which marker. All these are analyzed whenever we are doing a biopsy, and after that the treatment is started. And in today's world, for lung cancer, without this mutation testing, molecular testing, there is no treatment for lung cancer. Basically, we'll be flying blind. It's like, just blindly giving chemo without knowing what particular type is that. That can be done in a rare scenario where nothing is available, but in today's world, in India at least, it's not a problem. Any major, I wouldn't even say major metro city, it will be like even a tier 2 city will have all these facilities, or the facilities for getting it and having the testing done.
Thank you, sir, for such all the insightful information that you've given us. Any takeaway message that you have for our viewers before I sum up the session?
Yeah, probably I'll just say two things. Quit smoking. So one
Yeah.
simple thing most of us can do, most of us can do, not even most of us, most of us can do, quit smoking, and probably use a mask. That again is going to help, especially in places like Delhi, or even in other places. Wearing mask is relatively safe, not just from a pollution perspective, but also from infection control perspective. So these two are things that can be simply done, and go to the right place for treatment. It's not just you go to any, you have specialists available across the country today, and we can make use of the recent trends and treatments which are available. Today, there are patients where you don't need chemotherapy, where you can just treat them by giving immunotherapy or targeted therapy. There are tablet forms of therapy available, even in stage 4, where they go on for years together. Previously, that was considered to be impossible. Now we have stage 4 patients who survive for 5 years and more, just taking a tablet form of treatment with relatively minor side effects in that. So all this is possible today. So go to a specialist center where you have these available, and we can go ahead with the treatments.
Thank you so much, sir. For our viewers, as scary the lung cancer might sound, uh, prevention is always better than the cure. So quit smoking, wear a mask in polluted cities, and unfortunately, if there is someone who has got cancer, there's a hope. There are treatments available. The recovery is really good, and all the all the latest technology is available for us to get rid of the disease. And specialists like Dr. Balaji is also there for helping patients worldwide. Thank you so much, sir. Thank you for the insightful information. We are glad that you joined us.
Thank you, ma'am. Thank you for the opportunity. And again, one more thing: if you are a smoker, one quit. Second, get yourself screened. That is also easily available in even government hospitals. So do get a CT test. That is something that. Thank you.
Thank you, sir. Thank you.
Thank you, everyone.